Right. Well, hi, everyone. It's a pleasure to kick off the first Cochlear Center for Hearing and Public Health Seminar series of the year. We're thrilled to have Michelle Arnold here from the University of Florida, who I'll formally introduce in a minute. A couple of logistics. The seminars are generally held the fourth Thursday of the month from 12 to 1 p.m. They'll be here or on Zoom. So this month we have Michelle Arnold here. Next month we have Jin-Kook Lee from the University of Southern California. This will be virtual, but we'll also gather in Page Hall together to attend this talk. January 25th will be Brent Edwards from the National Acoustics Laboratories in Australia. Note that this one will be at 4 p.m. given the time zone difference, and will also be virtual. February 22nd, we'll have Heather Whitson from Duke University. And March 28th, we'll have Danielle Powell from the University of Maryland. And save the date for Friday, April 19th, that is Cochlear Center Research Day, which will have our keynote speaker, Erasmus Leroy from the Trinity College Dublin School of Medicine. We look forward to seeing you at all of these upcoming seminars this year. Couple logistics. So if you're joining us in person, please hold the questions until the end of the presentation for inclusion in Q&A. If you're joining us through Zoom, you can use the chat function to ask questions, and we'll moderate the questions that come in through chat. Closed captioning is also provided in Zoom. You can use this link below to access the transcript. And if you have any technical difficulties, please feel free to reach out. And the seminar is being recorded. All right, so I'm thrilled to welcome Dr. Michelle Arnold here from the University of South Florida. Dr. Michelle Arnold has her AUD and PhD and is an associate professor in the Department of Communication Sciences and Disorders at the University of South Florida in Tampa, Florida, and also a clinical audiologist with license to practice in the state of Florida. She completed her PhD in aging sciences with a concentration in health policy and long-term services and supports. Dr. Arnold engages in a variety of interdisciplinary efforts to understand the impacts of public policy and legislation on hearing health care access and use. And her long-term goals are to improve accessibility and utilization of hearing healthcare services through targeted intervention efforts designed to address clinical, organizational, and structural barriers to care. With that, I'll hand it off to you.
Thank you.
I'm gonna quickly change this view.
You're gonna change the view? Okay. You know, that is a much younger picture. It's a good one, all right. That was like, something like 8 or 9. I might need an update. I don't really want an update because that one is just
It's a great photo.
I look young.
It looks like you.
It's young me.
It still looks like you.
Thank you. And a super blonde me back when I had time to go and upkeep with that. I don't have the time these days. That's not why you're here though, but thank you for joining. I'm so excited to talk to you today about some work we've been doing, some multidisciplinary work we've been doing to better understand private insurance, hearing aid mandates, and how they are potentially impacting access to hearing healthcare. And so this is a project that I am co-leading with our PI, Mike Pesco, and our other co-investigators, Brandy Lipton and Stacy Kirshner, and Serena Phillips. And Brianna Heslin is now JD. She was an amazing law student that worked with us on this project, and Madison Dowdy is almost finished with her PhD. Serena Phillips is an amazing data analyst at Georgia State University, along with Stacy Kirshner, who is the director of the Center for Law, Health, and Society. And Brandy and Mike are both health economists with very long CVs. And I've been learning a lot about some of the analytic approaches that health economists use to look at these data, and it's been a great experience working with this team. So highly recommend, if you have the opportunity to become involved in interdisciplinary teams, even outside of the healthcare arena. I never thought I'd be working with lawyers, but I truly enjoyed it and I learned a lot. The project that I'm going to talk about today was funded by the NIDCD. However, the content is our responsibility and it doesn't necessarily represent the NIH views on hearing aid reimbursement or access. And today I'm going to talk to you about hearing health policy and the landscape in the United States and some rationale for why we conducted this project. And then really dig into some of the methodology, particularly that surrounding the policy surveillance and the legal epidemiology, which is a new term I learned from Stacy Kirshner, that we conducted to identify and analyze the various statutes that we uncovered. And then I'll share some preliminary data on our estimated numbers of youth and adults that are covered, have guaranteed coverage by a private insurance hearing aid mandate. And then some discussion, limitations, future directions, and hopefully some conversation with you guys today, guys and gals. And I guess we're saving questions till the end, correct? Okay. If you have like an absolutely burning question that you cannot understand the rest of the presentation, it's okay to ask me. If something is completely unclear, I'd rather know sooner rather than later. Here what we're looking at is a table of some recent data on hearing aid uptake in the United States. And this is data published from the, it's a data set I'm not familiar with, the US Market Report Suite for Hearing Devices. And it's published by iData Research, Inc., which is a private company that collapses and prepares market data for different health professions and healthcare IT, so like computerized medical records, et cetera. And the reason I pulled this data is because I think the most recent, outside of like the market track stuff that we see come up every year from the Sergey Kochkin Health Hearing Institute, or I'm not, sorry if I'm getting that wrong, which is published every few years in the hearing review, but it's not peer reviewed. Not that I'm doubting their estimates, but I like to use peer-reviewed evidence when I'm trying to build a rationale for something. I think some of the most recent data we have on hearing aid device uptake is from the Chen and Lin paper, and that was 2010, 12. So it's time for an update. This isn't that much newer than that, but these are some estimates of the hearing aid market size from 2013 to 2015 in the US using this data from iData. And oh, here we go. And so what you can see here is they have the total US hearing aid candidate population, so people who could potentially benefit from hearing aid use, and then the total number of devices in use. So we can see big gaps in individuals who could potentially benefit from hearing aid use and who are using or potentially using hearing aids, right? These are just based on receipts, I think, purchases. And I did the math for you. So it's about a 21% uptake rate, regardless of if we're looking at 2013, 14, and 15. And this is consistent with other estimates we have with the Kochkin data, with the Chen and Lin data. So we're at about, somewhere between 20, 25% hearing aid uptake. And again, this is among people with clinical hearing loss that could potentially benefit. One of the barriers to more adoption of hearing health interventions is a lack of coverage, particularly in the United States. As I'm sure you're all familiar, there's a statutory exclusion of covering hearing loss treatment in the form of hearing aids. That's been with us since the Social Security Act was passed. And here's just some very specific language that describes that statutory exclusion. No payments can be made for any expenses incurred for hearing aids or examinations for hearing aids. So the majority of people in the US with hearing loss are older adults. The majority of older adults in the US use Medicare for their health insurance and health care needs and coverage. And since Medicare is under the Social Security Act and there's a statutory exclusion, a lot of older adults have limited or no access to treatment for hearing loss in the form of hearing aids. Cochlear implants, osseointegrated devices, those are covered, but it's a very small proportion of individuals that are in need of those devices. Still, a need is there. The need exists, but compared to those who could benefit from use of a hearing loss or a hearing aid, so those with mild to moderate hearing losses, there's a lot of barriers to getting treatment. Some of the approaches to increasing access and ability to use hearing intervention or to uptake hearing intervention there's been some traction in this. I'm sure you're all again familiar with the OTC Hearing Aid Act that was introduced in 2017. It was passed very easily and readily. However, there was a significant delay between the passage of this and the FDA final rule regulating the devices, probably because COVID, they had more important things to do. They were trying to get vaccines out to us. So while I think that hearing aid access is great, I also appreciate the reason for these delays. So the final rule on the device regulations was released in August 2022. And this is like all the rules for packaging the devices, how loud they can be, the return policies, et cetera. So lots of rules and regulations that were passed by the FDA. Did any of you actually read the regs? It's a lengthy document. Am I not on the right slide? Oh, what did I just do? Oh no, what did I do? No, here I am. Okay, sorry. Did any of you read the regulations? They're like pages and pages and pages long. I'm sure Frank read the regulations. He probably wrote the majority of the regulations. Let's get real. Or had some influence in that. And good, I'm glad we have people like him advocating for our field and our shared interests. But what this did is establish a new class of hearing aids, OTC hearing aids, intended for adults with mild to moderate hearing losses and no medical contraindications. And this availability of OTC hearing aids may increase access and affordability, but there's still no option for severe hearing losses or worse, or for youth who needs hearing intervention or hearing aids. So there's still some gaps there. Some other movements in the legislation that seek to increase hearing healthcare access include the Medicare Audiologist Access and Services Act, and this proposed amendments to the SSA to address some of these statutory barriers, but it only included things like services that are already covered, but for a physician to do. So really this was like a bill to enable audiologists to bill for these services, right? So things like vertigo treatment in some states and in some practices, audiologists can't be reimbursed. Cerumen removal, telehealth services. Actually, we can bill for telehealth services now because of COVID, but some of those other services that already were covered by Medicare, this was just so an audiologist could bill for them. I have my own opinions on does that truly increase access. You can probably guess what those opinions are by my tone of voice. It's just people getting paid for things that are already being provided is my personal thoughts. That's why I put the disclosure in the beginning. This is not the viewpoint of anyone but me. So there are several benefits of hearing aids. However, there's no federal mandate for coverage for private insurance, Medicare or Medicaid for all ages. Some states have coverage for Medicaid, and we'll talk about that towards the end of the presentation in the next steps, but there's not a federal mandate. So there's no guaranteed minimum requirement for payers to provide hearing loss treatment in the form of hearing aids. In the absence of any federal action, several states have adopted private insurance hearing aid mandates, and we looked at those in a great amount of detail. One limitation of the state mandates is they don't apply to self-insured group health plans. And these are estimated to cover about 58% of privately insured workers in 2021. That doesn't mean that self-insured group plans aren't providing the coverage, but they're not required to. So those individuals aren't guaranteed that coverage. And I'll talk about that in a minute as well, about the ERISA, the Employment Retirement Income Security Act, and it's federal legislature. So it supersedes state level hearing aid mandates. I realize I'm really getting into the policy weeds here. I'm sorry. So I hope you have questions for me. And if you don't, it just means I'm explaining it very well. But I promise I'll give a little detail on ERISA as well and why that's such a it's like kind of a head scratcher. So in the absence of a federal mandate, a lot of variability exists between state level legislation and people's access to hearing care based on where they live. And this is relevant for those insured by private payers, as well as Medicaid, Medicare Advantage, and particularly Medicare Standard, because they're probably not receiving any coverage. But that was some of the impetus for this current work. So the purpose of the work was to use health-related policy surveillance methods. I'm going to get into how we did that. And our goal was to create a database of US state and territory level private insurance hearing aid mandates and summarize and code the salient features of the legislation across time. The reason we wanted to do this is because policies can serve as determinants, implementation strategies, or the evidence-based thing to be implemented, or other variables in the causal pathway to hearing care access. And I pulled this because I just added this to the slide because I was part of this dissemination and implementation science with John the past couple days, this workshop on the NIDCD, and trying to think of how policy work fits into D&I. And it does, it has a place there. And these are some of the ways in which it does fit in. However, there's a major lack of guidance in conceptualizing how we do this, when do we do this, how it should be empirically investigated. And so one of the things I learned as part of this study was really working with the legal experts in the Center for Health Policy and Law to learn how to really do this work correctly. And it was great. I'm excited to share it with you. We also sought to quantify the yearly averages of the share of privately insured beneficiaries covered by a hearing aid mandate. We used nationally representative data to do that. And what I'll share with you is just some preliminary stuff. There's a lot of plans for this data set, but we did those estimations as a first step, sort of. So here we see a framework of policy surveillance and legal epidemiology, and this is for the Center for Public Health Law Research. A lot of this work was sort of conceptualized and spearheaded at Temple University by Scott Burris and colleagues. And you can see here where the practice of legal epidemiology, or the study of laws and legal practices as cause of disease or injury, or how laws and legal practices can serve as interventions, how they fit into a larger model of public health law and practice, including things like legal counsel and representation, and then legal research. So I think this is a nice way to sort of see how the health aspects of healthcare legislation kind of fits into a larger world of public health law and practice. So for our study, we used consensus bylaw guidelines based on some of these legal epidemiologic methods, which you can see here. So we worked through defining the scope and conducting the background research and developing coding questions. Those were the background and introduction of this presentation. Sort of that's the summation of that element of this policy surveillance and legal epi process that we underwent to develop this data set. Then for the methodological part, to continue on the collection of the law and coding the law, et cetera, we went through all of these various steps as recommended by Burris and colleagues, again, from Temple University. So I'm going to I've walked you through these steps. We've defined the scope. We've conducted some of the background research in terms of what is the legislation landscape look like, how many people are using hearing aids, where's the need, and the coding questions have been explained a bit here, and now I'm going to walk you through the rest of it. Oh yeah, this is my extra little Oh, I put it in twice. Yeah, just policies role in D&I science. It's been on my mind since that workshop, so. We have a lot of resources invested in the development of interventions, healthcare interventions, but very few of these kind of translate to practice and policy. That's sort of the purpose of this whole workshop that John and I attended. So again, just trying to think of how this project fits in there. Okay, so how do we do this? For the systematic collection of the law, this took place from June 2022 till January. And we included statutes from Westlaw and LexisNexis, which are two legal databases. And we included statutes if they described any type of private insurance requirement for covering hearing aids and were published and effective between 1997 and 2022. We did not include statutes that regulated the pricing of hearing aids or the licensure of audiologists or return policies or things like that, which there are more of those than anything else, which is kind of funny that our laws that regulate our profession for those of us who are audiologists are more focused on like how we're getting paid and how our products are labeled rather than how we're actually practicing audiology. So that was kind of a interesting finding as I went through these. This is just an example of some of the legal text that we uncovered and then sorted through to code. So we have these beautiful appendices of all the statutory language that was coded as part of a manuscript that's under review right now, but I'll be happy to share this appendix with anybody who's interested in it to see what was it that we actually looked at to make to come up with the results that I'm sharing today. Each state or territory that we coded constituted one jurisdiction. And we got started by collecting all of the statutes from two jurisdictions, and we selected Illinois and Connecticut because these were two that we knew had coverage for both children and adults through private insurance mandates. Sorry, I need a drink of water. Getting my little like Kim Kardashian voice is coming. Good morning. There's this mom that I walk by every morning on the way to school when I drop my daughter off, and she's just, I don't think she can speak outside without having vocal fry. And she's always like, good morning. Drives me crazy. Oh, excuse me. So we collected the initial subset of mandates, and then we worked through our coding scheme until it was replicable. And I'll share some details on what we coded on the next slide. Then 80% of our jurisdictions were redundantly coded, meaning Brianna or Madison did the first round of coding, and then myself or Stacy did the second round of redundant coding, just to look for consistency between coders, which we had high consistency. When we disagreed, we met weekly and we discussed our inconsistencies. And we coded whether a mandate was in place. Very importantly, we coded the date effective. We coded for mandate exceptions, ages covered, and the comprehensiveness of coverage. And this was based on best practices hearing aid provision outlined by professional organizations like American Speech Language Hearing Association, the British Society for Audiology, and American Academy of Audiology. They all have best practice guidelines. And we also coded for cost sharing allowances. There's a link here, and I'm happy to share my slides to the current version of the hearing healthcare policies that we coded, including the longitudinal data. Not a lot of change across time because most of these mandates, as you'll see, are relatively new. So they haven't been in effect long enough to see change, but we are updating them annually. We just went through our first round of updates over the summer, and there have been no significant changes other than Vermont's statute set to go into effect. It's been passed, but insurers aren't required to provide the coverage until January of 2024. So that's the biggest thing we found. So as part of the preliminary data analysis, we estimated the share of annual privately insured population of youth and adults. in the states with private insurance mandates from these years. And our data sources were our hand collected policy data, and we also used the American Community Survey data. Well, the honorary we, like I obviously didn't do this. This was the health economist that did this. We linked our hand collected policy data to ACS data for individual age, insurance, state of residence, and year variables, and then the MEPS insurance component data. And this was to estimate the proportion of the workforce that had fully insured group plans through their employer. And so just a note on the ERISA, the Employment Retirement Income Security Act of 1974. This is a federal law that sets minimum standards for most private corporation health insurance policies that choose to pay for their own workers' health insurance. They assume the risk for those that are insured, as opposed to a third-party payer assuming the risk. Meaning if someone files a claim, then the corporation itself is going to pay for the medical expenses associated with that claim and not the insurance company. It's common for a third-party administrator like Aetna or Blue Cross Blue Shield or United Healthcare to manage these plans. But if you have employer-sponsored health insurance and work for a private industry, your coverage is likely self-insured. And so these plans are not subject to state insurance regulations. This federal requirement supersedes any state level laws. So private corporations, even if they are paying individuals in a state that has a mandate, they are not required to provide the hearing aid coverage in that state. However, that being said, many private corporations voluntarily opt to provide this coverage. It's difficult to know how many do and to what extent they do. That could potentially be a future question. So now that we've got that out of the way, we can start to make sense of the results that we found and think about them in terms of access and what's on paper, right? Potential access, not necessarily realized access. So there's a difference there between what. And I think of potential access as what does it say on the page and who's actually, what does it say? What do the claims say, right? So the potential access says who could potentially get access, who's getting it paid for, but then the claims are saying who's actually using it. And what's going on in between those 2 points is a lot of it is unknown. So maybe some of this work can elucidate that. Start that conversation. So we identified 28 jurisdictions with private health insurance mandates. We retrieved them for 26 states and 1 US territory. And Vermont, like I said, is set to go into effect in a couple months. Good job, great. Go Vermont. What are they? What's their animal? Do they have like an animal in Vermont? The Huskies? It's like Connecticut. Husky Health. I have all these also. I've been working on the Medicaid piece of this, and every state has like multiple Medicaid plans, and they all have like cute names like Husky Health or like Peach Health or like Little Peaches for the kid. It's like swimming around in my brain. Vermont has one too, but I can't think of it. I don't think it's Maple Health. It's like, I don't know. Irrelevant to this conference. Very tangential. I'm sorry. Okay. We found a lot of jurisdictions that had mandates that were weakened by exceptions, meaning kind of loopholes or allowances for not covering the hearing care through or hearing aids. And so 2 states, their mandates only required insurers to offer optional coverage, meaning that anyone enrolled in that insurance plan would then have to pay extra for the optional coverage. It wasn't like a minimum required coverage. So this would increase out-of-pocket costs for health coverage in these states. 3 states had exceptions for small employers, meaning that their small employers were exempt from providing the coverage, and in each state, how they defined a small employer was different. So I think some of them defined it as like 50 workers or less, some of them defined it as 15 workers or less. And there were, I can't remember which was which, but they each had a different number of what they defined as a small employer. There were also an exemption for states if the benefit costs exceeded 1% of their annual premiums, meaning if they paid more than 1% of what they got back from people enrolled in the plan, then they were exempt from providing the coverage. And you can see that there's some redundancy in the states that have exceptions here as well. So Illinois had a lot of exceptions, Rhode Island had a lot of exceptions, Georgia had a lot of exceptions. These potentially weaken the mandates, right? They limit access based on some of these things. 2 states only mandated hearing aid coverage for state employees and dependents. And Texas had a trigger provision that would cause the mandate to dissolve, cease to exist if the Centers for Medicare and Medicaid Services determined it exceeds the federal essential health benefits. And it does, they've already determined that. So it is unknown how Texas covers hearing instruments at this time. Is the mandate meaningful, I guess is the question. Oh, sorry. I'm so used to like clicking on the mouse or pressing the button. I forgot I had this guy here. So now that you've learned a bit about the process of how we identified the statutes, the inclusion criteria, a little bit of how we coded, and some background on the exceptions, I can give some more in-depth results based on some of the other salient features of these laws that we coded. We found that the majority of mandates covered youth. The mode maximum age cutoff was 18 for 13 of our states that we uncovered mandates for, and 7 had no maximum age limits, meaning they were covering all ages, including adults. And that's truly where the gap in coverage exists, is with adults. While it is really important for youth coverage, there's a lot of other avenues for youth to gain access that is federally mandated through a blanket federal mandate for all 50 states and territories to provide hearing aid and other hearing intervention treatment under the early screening, prevention, detection, and treatment, the EPDST Act, and also through the Children's Health Insurance Program, which has a broader scope of coverage and is meant to capture those kids in between the Medicaid covered youth and those that families or caregivers or parents, et cetera, would have the means and resources to be able to provide the hearing care or the intervention themselves. It's kind of like it's for the in-betweens, basically. And adults don't have that option, right? We found also a lot of variability in the allowable frequency of benefit use. So how often are these people able to get new hearing instruments or return for services? And it varied from 24 months to 60 months. The most states had a mode or a benefit period of 36 months, so 3 years. That's consistent with not so much the lifespan of a hearing aid, but more like the lifespan of how long the manufacturers will service the hearing aids. So when I first started practicing as an audiologist, there was new technology coming out probably like twice a year, but individuals they call it the legacy technology, you could still send their devices in for service if they were breaking and the company would fix them, sometimes for a cost. Sometimes it was still covered under the warranty. But what we're finding now, actually, even as part of like the larger Achieve study, which is not relevant to what I'm talking about today, but we have a lot of participants who are their hearing aids probably would continue to function if they would be repaired, but the company will no longer repair them. So they're all having to move up in a new level of technology. This is fine if you're enrolled in an RCT where everything is being provided for you without additional out-of-pocket costs, but what about individuals who have a hearing aid benefit use of 60 months and they need to repair their hearing aid and the company will not service the hearing aid any longer? They have to wait 2 years, 3 years to get a new device. So that's very problematic. That there's so many issues, right? Like a hearing aid could probably last 10 years, but if the companies aren't going to service them after 3 years, it's a problem. What happens if it breaks? You know, it could be one tiny little part they have to replace instead of the entire unit. Charge for a hearing aid repair is usually on the order of like $300 to $500 versus a whole new unit can be up to $3,000. So this seems like maybe not an important element of the regulate or of the statutes, but it actually is. One state did not specify the allowable frequency of benefit use, which is leaves clinicians and payers with a head scratch. Like, well, what do we do? We also coded for the total coverage amount per period of benefit use. So with each of those, 36 months, 60 months, what have you, how much money could be spent during that time, right? So 17 states jurisdictions, sorry, because we included territories as well. They defined the maximum total coverage benefits, and this ranged from $1,400, which doesn't even buy one hearing aid, by the way, to $6,000, which barely buys 2 hearing aids. And 8 state statutes do not specify coverage amounts. And somewhat related to this is the factor of cost sharing, which, are you all familiar with what cost sharing is? It's like how much a person will pay out of pocket for a service, and it can be defined as a copay or a percentage. And typically defining cost sharing is good, right? We want to know how much we expect to pay out of pocket when we're going to make a purchase, how much of a dent it's going to make in our annual deductible, et cetera. A health related purchase, I should have said. So most jurisdictions with mandates allow cost sharing, but they curtail it. And the majority of these statutes just fold hearing aids into the other language that relates to durable medical equipment. So it either applies to the deductible or has a pre-specified co-insurance rate, typically and somewhere between 20 and 40% based on the plan. Only Arkansas explicitly prohibited cost sharing. Good job, Arkansas. So no out-of-pocket cost. But 7 states do not specifically restrict cost sharing in any way, which actually opens a door for them to charge very high co-insurance rates, and can be, again, we didn't code this as an exception, but it is certainly brings about the question of, is this going to reduce access if we're charging co-insurance rates that are similar to the cost of just paying for the entire device and the services associated out of pocket? How much is that actually expanding access or providing access to the people who are insured in these states? So here we have a display of our preliminary data analysis, and it's showing that, recall that this is our policy hand collected data with the ACS and the MAPS insurance component data. And what it's showing is that between 2008 and 2022, you can see the proportion of youth and adult guaranteed coverage, which is delineated by the markers that have the top 2. So covered by any mandates versus the, I'm sorry, I said that wrong. Covered by any mandates is not necessarily the guaranteed coverage, but that is considering that proportion of individuals in those states that are potentially being provided health insurance by a private corporation insurer, so fully insured group plans. And again, that's to the whim, the higher lines, right? Those are to the whim of the private corporation. So they may or may not be providing that coverage. Now, if we consider that none of them are providing that coverage, none of those private insured corporations are providing that coverage, you can see the difference in the potential access, particularly for the adults. So what we're seeing is that for youth, the proportion of privately insured individuals with mandated hearing aid coverage is steadily increasing. It goes from about 3% in 2008 to 18% in 2022, but we don't see much movement in adults. Part of that is because several states that cover for youth do not cover for adults for private insurance, and these are the adults. These are the, if we take out all of the proportion of adults covered by a privately funded corporation, it's the bottom line. So we see we've got very little movement here, and it takes a jump right here because this is when a lot of the mandates were passed. Was in the year 2018. Wonder it probably time synced to a lot of things happening with the OTC Hearing Act and that President's Council of Advisors on Science and Technology report on, making hearing care more accessible and affordable for adults. The NASM report, or maybe it was IOM at the time. I don't know when they changed names, but there was a really great sort of, that's what I'm looking for, sorry, like a
Consensus study.
consensus paper, thank you, John, on affordable and accessible hearing care for adults in the United States. So this was all happening like right around here this time. And so from a policy perspective, those windows of opportunity, it makes sense that you see a jump both for kids and adults, but for adults, not so much. So we have less than 4% of privately insured adults living in a jurisdiction where you're guaranteed, if you have a private insurance plan, that you're guaranteed coverage for a hearing aid. So some of our takeaways were, we are very excited that this is one of the first studies to examine US state and territory level private insurance mandates for hearing aids using such a granular policy surveillance approach. We really dug in, as you can see, and we found a lot of measurable variability between states that had the coverage, and this is consistent with some previous work that I did with my PhD advisor, Kathy Heyer, looking at the cross-sectionally meaningful differences in generosity of Medicaid coverage. And our findings demonstrate areas of variability that are similar to other conditions where publications and data sets are available that incorporated a similar type of policy surveillance approach. So autism and mental health care for adolescents, again, they demonstrate, and that's why this Douglas team, and actually I think Scott Burris is part of this team as well, who was one of the fathers of legal epi, and they showed similar variability in age limits, costs, and covered treatments. Again, we found substantial gaps. Most mandates pertain to the youth. However, older adults have higher prevalence of hearing loss. 9 jurisdictions had coverage limits less than $4,000, which is lower than the median cost of a pair of hearing aids. And so what is that? What are those dollars going towards, right? There was a major lack of statutory language regarding the cover of oral rehabilitation services. And for youth, this is a crucial area needed for learning how to talk, attending school, potential risk for academic and language, speech and language development delays without auditory input, and the accompanying rehabilitation that goes along with it, or habilitation. So if we have coverage limits lower than the median cost of hearing aids and never exceeding $6,000, how are these providers being reimbursed for these services, or are they even being provided without patients and families being faced with high out-of-pocket expenditures? These are some of the questions that we have going forward. The study had a lot of limitations. Our findings were based on the coding of legislatively enacted mandates. We didn't include administrative bulletins, codes, or regulations. It gets really messy when you start including that, as we're finding in our Medicaid data. We are including it in the Medicaid data though, because it's some of the only places where these types of coverage policies are tracked. And again, our estimates do not estimates. Our estimates are estimates. That's how we say it in Florida. Our estimates do not capture how many group health plans voluntarily provide coverage. So that's a major limitation. Our next steps are to finish our Medicaid policy surveillance database. It's almost so close to being done. We're making our data sets public for inclusion in population health studies, and our immediate next steps are to use difference and differences quasi-experimental approaches. We have planned analyses to, are y'all familiar with that approach? So you're looking at the, I know you are. So the difference and differences approach is a way to incorporate changes across time. It's used a lot in policy work to demonstrate the impact of a policy, and it uses the time or the date as an interaction term. And so the first step in looking at the first difference is the difference within the state itself in our terms. So what is the difference in hearing aid uptake based on claims data after certain policies were implemented? So private mandates and Medicaid regulations went into play, and that's the first difference. And then the next difference is looking at a more macro level, like what's happening across all the states and territories. What are the differences based on the dates? And then you can sort of control for variability by looking at, taking out sort of the difference in trajectory is what's important between what's happening on the federal level and then the state level. And then that's like, that is the difference of importance. Did I get that right? Sort of. Okay, thanks. All right. I'm glad you're here. Okay. So we're going to do that, and we're going to use our outcomes of interest are claims. So how many people are uptaking hearing aids, out-of-pocket payments, looking at differences based on sex, age, race, and ethnicity, high deductible health plans, etc. Those are our next steps. And hopefully some of you have great ideas on how to use this data as well. And that's it. Thanks. Thanks for listening.
Well, this is our QA session. Does anyone have any questions for Dr. Arnold?
I'm glad you have a question. No, it's not a hard. Well, I have a hard question. Here to answer the hard questions.
Awesome, Michelle. Thank you for that presentation. I think this is very, very important work to kind of, like you said, document the variability in coverage and potentially offer us an opportunity to do quasi-experimental studies of what are the differences in outcomes. I have a few questions. The first is when you looked at mandate hearing aid coverage, did you look at whether that coverage devices versus follow-up services? Mm-hmm. And then, yeah, could you talk a little bit about the difference there?
Yeah, absolutely. So there was a healthy lack of statutory language regarding the covered services, right? So most of the mandates approached it from the model that in audiology, I think we really need to get away from is this like sort of concept of a bundled model. Like you get this much money to do everything you need to do, including follow-up, blah, 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 and then just a list of like whatever the audiologist scope of practice is in that state. Some states did a better job at delineating what specific services should be covered, but none of them were like, you have this much money for this much money for this, et cetera. It's all in like this bundled language. Does that answer your question?
Yes, it does. And then I'm trying to think. My second question had to do with what you mentioned is with Texas addressing dissolving the mandates if CMS determines it exceeds the federal essential health benefits. I had never heard of CMS determine essential health benefits. Could you talk a little bit about what that is? And
Oh, those are like the mandated minimum benefits that are covered under Medicare. So there's like a list of them, and hearing aids are not on that list.
because of the statutory exclusion.
Yes, exactly. I don't know what everything is on that list, but I can find it for you and give you a list of it. But there's like federally mandated essential health benefits, and it's like a bullet point list, and they're kind of vague, but hearing is definitely not included.
And then,
Like long-term care
okay.
is one example that I'm familiar with because of my background. Yeah. I was going to show you the current version of policies, but it's making me do stuff. So I'll just email it to you.
And then my final question is, are you aware of any studies out there? Because I'm not, with regards to looking at the cost benefit analysis of essentially, if we cover hearing aids and we look at longitudinal outcomes, this is the net savings we can expect based on how much we spend and how much is not spent because of certain outcomes. Are there any studies that you know that are like that out there?
There's like one or two, and they're great. They're really important studies to read and understand. And I'm happy to share them with you. And I'm not going to say any names out loud because some of the people, I love them who are involved in them, but they're not I don't want to say they're not well done. They just lack like the type of methodology that really answers the questions, right? There's no health economist. There were no biostatisticians working on these papers, and they're very crude. The results are very crude, and they're dated. The studies are very dated as well. They're from like the 90s and early 2000s.
So coming out of the D&I, the dissemination implementation workshop with you, would you say that that's a target that as researchers, we should try and invest some time and resources in next in order to advocate for these public health mandates?
Yeah. And I hope to be working on some of that work with some people here. So yeah, that's absolutely some of the next steps, and I think is really important. It's difficult. Some of the questions are difficult to answer. Again, any estimates are going to be somewhat crude, right? And I was talking about this earlier with Allison, because a lot of the cost, the reimbursement that clinicians receive, a lot of these are dictated by private companies, and they're not very forthcoming with their costs and how much they're charging other people. So for example, Medicare Advantage or Part C, when I first started my PhD program, I'm sorry, Allison, you have to hear this again. I remember it was like ingrained in our minds, like 30% of older adults, 30% of Medicare enrollees are enrolled in a Part C plan. And I recently looked at, as part of some of this work, and it's like 58% now of adults are enrolled in a Part C plan. So we're missing a large proportion of that claims information. If the companies if it's not linked to a nationally representative data set, it's not like these companies are giving us that info for free. So they don't want us to know how much money they make. Like, I'm sorry, it sounds cynical, but it's true. They're private corporations. And
Awesome, thank you.
my opinions, of course. Go back to that first slide. These are my opinions.
Any
Those are
other
good
questions?
Thank you.
Okay, thank you so much for coming, Michelle. I love the presentation. I do have a question. Do you know if any of these mandates vary have any requirements with respect to who's providing the service? Versus like an audiologist versus going to Costco?
Yeah, so we have all that coded in the longitudinal data set that's linked here, and I'll share with you. But yes, I would say most of them do. Anything that is not specified in the language is coded as not specified. So the majority of plans that did specify that information allow either an audiologist or a hearing instrument specialist. So in one way, that's good, because then they can go to a Costco, or we don't need to get into a conversation about the differences in a private practice and a Costco. That's for another time. But in one way, that is a manner in which some of these statutes do expand the access, because they do allow the coverage. For the adults, for the kids, audiologist only in almost every single state, which is good as well, right?
Mhm.
I mean, from an audiologist perspective, I think so, because we learn a lot about in our training on speech and language development and, fitting practices specific for maximizing the child's residual hearing through these amplification and like classroom acoustics. We get all that background and training, but a hearing instrument specialist does not get that. So that's why it's probably good that an audiologist is the one fitting.
All right, thank you. Do we have any questions?
I have one more question if you have time. Have you done any mapping of like hearing care needs by state and mapping that onto like states that have needs? Like I know there are some states that have like a high like agriculture
Yeah.
population that has more hearing loss, things like that.
Yeah, we're starting to do that, actually. There's a paper under review that's mapping, as a whole other part of this project. I also assisted in working with a great postdoc in Mike's team. His name's Joey. He has a very difficult last name to say. It's Italian. It's a lot of CCIs. And Joey is working on doing some geospatial mapping of the audiologists and hearing care providers based on NPI, not based on all the data we have currently is just based on ASHA certified audiologists, but there's so many other people providing hearing care. So the national provider identification is probably a more precise way to do this. So he's incorporated that, as well as the proportion of individuals with hearing loss using in the states using NHANES data and our mandates as well, kind of like all layered on top of each other. And so that's actually, that paper has been written and is under review now. So I'll let you know when it's out, you can take a look at it. Yeah, he's cool. You have to meet and should introduce you guys to him if you want someone who's really good at working with NPI data. He's like a genius with it. Some of the things that he does, I'm like, oh my gosh, how'd you do that? All the different taxonomies and collapsing them, and it's really complex.
Do we have any
Good questions.
on Zoom?
No questions on Zoom.
Any more questions?
Thank you so much. Thanks.
Thank you so much, Michelle.
Very friendly audience.
Lunch is in front
Across the.
and across the hall, and if you need, please stay and ask Dr. Arnold a bunch of questions. Thank you all so much for coming.
Thank you.